Good afternoon, Colorado. This is Bob Dorsheimer, Chair of the BHAAC Advisory. Today is a special session that we're coming to you today to talk further about the BASOs and the BASO process for the members today. And then towards the end of the presentation, we'll have a opportunity for community questions and input. At this time, I'd like to ask if we can go into roll call.
Sure, that's me. Okay, let's go through the list here and see who we have with us in terms of council members. Raquel Garcia.
Present.
Jesse Pocock. Dr. Stacy Oberly. Selwyn White Skunk. Noor Shaffi. Seth Watkins.
Present.
Great. Kay Ron Lee Liao.
Present.
Ash Anan. Jamie Ulrich.
I'm here.
Cameron Vigil de Teo.
Present.
Tasha Kankar.
Present.
Bob Dorsheimer.
Present.
Karen Renee Anderson.
Audio now unmuted.
Present.
Raina Shaner.
Here.
Catherine Washington.
Present.
Tina Rowe. Carolyn Hall.
Present.
Maria Martinez.
Present.
Rob Archuleta.
Present.
And Andrea Savanich. Okay, thanks, Bob. That's roll call.
All right, thank you. We do have quorum in the event. We need to have a vote. Again, welcome everyone to the special session of the Advisory Council. I have the great honor to turn it over today to Yumiko and Dr. Medlock for the presentation on the BASOs. Yumiko?
Great, thank you so much. It's good to see everyone. And Angelina, are you able to pull up our slides? I think there were a couple things we wanted to share with folks before we dive into the content. Thank you all so much for being here. I know this is our second special session around this topic of BASO design and care coordination. And so first and foremost, I just wanted to say we recognize that we are throwing a lot at you, calling extra meetings. There are big changes to the behavioral health system happening and timelines that have been set for the BHA. And we absolutely recognize that it is a fast and furious pace, and we are asking a lot of you members. We are absolutely committed. Angelina and I have been discussing with Bob, your chair, various ways to kind of set a more reasonable pace and rhythm with the council, making sure we provide plenty of opportunities for engagement around just understanding and learning the materials that we're putting out there. So we are committed to doing better and making sure we are making the best use of your time and being as respectful as we can, given the timelines that we are all under right now. So thank you so much for being here, for taking the time, and for being patient with us as we roll out these big changes. I also, before we dig in, we have quite a few public members with us. Welcome, everyone. Of course, everyone is always welcome. These are always public meetings with the council. And I think that is a testament to the fact, again, that we are up to very big things within the BHA. In particular, the topics that we're going to be discussing today. I know there are lots of varied opinions, thoughts, and perspectives because it is such a fundamental change to the structure of our behavioral health system. And so it is not surprising. We wanted to make sure we put up on the screen. There will be lots more information coming around these other opportunities, but wanted to make sure we shared with both council members as well as our public guests that the BHA is going to start rolling out more regular touch points, both for the general public and for our providers. So as you can see here on the screen, and again, we will be sharing much more information around these opportunities. We'll be holding a provider and crisis convening on the 19th. That's from 1 to 2:30, and we will continue those monthly. In addition, we're going to start launching BHA town halls every month, the first one being on January 25th. And these are meant to be both high touch points where people can understand what it is the BHA is up to. And for the provider convening, we're hoping to use those more as work sessions to really do deeper dives into some topics that are uniquely important to providers within our system. And then finally, hopefully you all have seen by now, there is an open feedback form on our BHA website where you can always submit feedback to the BHA. And we're also working on creating a process by which the public can engage directly with the BHAAC, today's BHA Advisory Council. So more on that to come. So all of this to say, we appreciate everyone's enthusiasm, interest, and engagement in these topics, and we are committed to making sure we have a regular cadence of public forums for various stakeholder groups to engage, not just this one forum. And with that, the last thing I want to say before kicking things over to Dr. Medlock, all of us wear multiple hats. And certainly the 20 of you on this advisory council wear multiple hats in your lives. Many of you are employed or work for providers or other entities within the behavioral health system or advocacy groups. And this council, I just want to center us that this is our council representing lived experience of those who have experienced firsthand accessing or not being able to access behavioral health services within the state of Colorado. And so we are here today to really represent the people of this state and what is in the best interest of people who need access to services and treatment. Again, we know there are so many different perspectives and ways of looking at these topics. And that's why we're setting up these different types of stakeholder forums. And for today, I just wanted to put out that reminder that for the next hour, right, during this council time, we are here giving voice to the people of Colorado and those who need services the most. So with that, I will turn things over to Dr. Medlock to dig into some of our topics for today.
Thank you very much, Yumiko, and Happy New Year to the council and to the people of Colorado who have joined us today. It's so good to see you. And as has been nicely teed up by Yumiko, our mission today is to really think about how does this BHAAC discussion help us co-create a people-first behavioral health system that truly meets the needs of every person in Colorado. Someone asked me, what are we looking for in terms of outcomes of this discussion? I would suggest for us that we're looking to find our why. We want to leave this discussion understanding why we believe what we believe, not necessarily which scenario we support, but we want to at least understand what undergirds those beliefs. Why do we think this scenario is better than the other? Why do we think this scenario will serve the people of Colorado better than the other? In the last meeting, when I shared my why, I want to also clarify that my why, in terms of why I support scenario one, does not mean the conversation is closed. We believe in community-informed practice in the BHA, which means that it's my job to be a good steward of the knowledge and skills that I have as commissioner, as a psychiatrist, as a policymaker, to give recommendations to community about what I feel is in the best interest of the people of Colorado. We can still disagree about that. It doesn't mean that my opinion is correct. Today, I do hope that we can at least come to an understanding of why we think that's not the best approach, what we're worried about, what concerns we have, and how we want to move forward to address those dilemmas and questions. I also want to clarify that when we talk about a BHAAC, a Behavioral Health Administrative Service Organization, and what that really means, I was asked to clarify, what are we really talking about in terms of people impact? The impact is that we want to have a way for the Behavioral Health Administration to be effective on the local level. That's really what we're talking about. So right now we divide our funds in 3 different streams. We have a stream for what community mental health centers. We have a stream for administrative service organizations that then contract with providers to do crisis services. We then have another contracting stream with MSOs to then provide substance use disorder service. What we're trying to do fundamentally is we want to create a single door for service delivery at the local level. That's what we're trying to do. So we won't have the BHA sending contracts 3 different directions. We want the BHA to be able to send contracts in a focused regional BASO approach so that the people of Colorado have more opportunities to access life-saving care. And so at the local level, the difference this makes is that there's less confusion around how to access care, how to navigate care. There's a key entity that is guiding and directing care coordination and ensuring that there is a network of providers to provide those needed services, whether it be behavioral health, substance use, crisis, or again, care coordination, care management. So that's the big idea. Now, this structure doesn't work unless we also have standards of care. And so I want us to connect our conversation today with a much bigger conversation that we've been having for several weeks around a rule and standard process that many of you have been attending. And so it's still the BHA's job to ensure that there is a process for requirements, credentialing, standards of care. How do we ensure quality of care at the local level? That's still the BHA's job. I do want to clarify that. And so this meeting is connected to the rule and standards process that many of the people of Colorado have been a part of. Those 2 are connected. Now, the BASOs have 4 main functions that are shown on screen: helping individuals navigate and access care, ensuring that we consolidate all of our admin costs that we currently have so that we can maximize dollars for the people of Colorado, ensuring that there is actually a continuum of services. What do we mean by continuum? We mean that from every stage, from prevention to recovery, that there is a number of doors to go through to access that care. That's what we mean. And finally, to ensure that coordination of care for Medicaid members happens in an efficient way as we collaborate with the RAIs, the regional accountable entities. Next slide. And so in our last meeting, we talked a lot about how to provide feedback and voice. And so I do want to just clarify timelines. We have on the call today, Health Management Associates that has conducted over 26 stakeholder sessions on BASOs. They have met with over 270 people across our state and those representing priority and marginalized populations across our state, including community mental health centers, regional accountable entities, law enforcement, public guardians, schools, etc. Today, we are trying to clarify how specifically do we want to move forward as we think about actually beginning to build the BASO structure starting this spring with the negotiation process and actually standing up the BASOs by July 2024. I do want to clarify that I would love to move much slower in this process. However, we cannot do so because lives are on the line. And we've been asked by statute to ensure that these BASOs are up and running by July 1, 2024. And so I'm trying to ensure as commissioner that even though our timelines are tight, that we're still thoughtful in how we approach this process. Next slide. So in the last meeting, I showed a lot of data, and I'm going to try to get away from that today so we can just talk heart to heart, person to person about these decisions that we have to make. In scenario 1 on the next slide, I showed in the last session that this scenario gives us most similarities in population in BASO 1 versus BASO 2. That according to our data analysis, these populations are the most alike by need, Medicaid utilization, behavioral health needs, and healthcare use. Why does that even matter and what does that mean? What it means is that if I can somehow ensure that the 2 regions have roughly similar needs, then I think that would be connected to a logical process for how I ensure those BASOs are adequately funded. So if I just draw the regions anywhere, right, and I'm not sure what the needs are in that region, then if I just say, okay, you get 50% of the money, you get 50% of the money, you can see how that probably is not going to work. So in this scenario, my why today is that I believe this is a scenario that we can build upon to ensure that at least there's equality in need between the two regions. And so if I happen to send the dollars through in a 50-50 process, that I'm more likely to meet the needs of the two regions than some other process. All right. So that's the commissioner's why. And of course, our goal today is to hear about other concerns. I do want to address the question of splitting the Denver Metro. I want to acknowledge that in this scenario, the Denver Metro is split in a way that is consistent with how the Rays already split the Metro. So this structure is still built upon ensuring that we don't create another split that's different than how Medicaid and the Rays work. I do want to clarify that. So we're not creating a new split, all right? Certainly the Metro is split in this scenario, but it's not a different split, all right? And so one of the things that we clarified is that if you want to think about how the BASOs are structured by Ray, essentially BASO 1, which is blue, is Ray 1, 2, 5, and 6, and BASO 2, which is green, is Ray 3, 4, and 7. All right, scenario 2 is the scenario where we had one BASO that's really focused on the Metro, not including Park and El Paso County, and then a second BASO that's the rest of the state. All right, and again, we're here to understand one another's rationale. The reason why I'd be concerned about this scenario is because our data shows us that the populations in rural and frontier Colorado are quite different than the population in Metro Denver. And so if we chose this scenario, we would have to be able to acknowledge that our funding approach for ensuring service delivery would be unreliable, because we would be trying to guess about how do we fund these BASOs when the populations are so different. Then we looked at scenario 3. And scenario 3 tries to carve out a bigger part of the Metro. It adds in Park and El Paso County, and then has a second BASO for the rest of the state. This scenario presents similar risk to scenario 2. We're going to have one region with a much lower population. So we know that rural frontier Colorado has a third of the population of Denver Metro. But we also know that rural and frontier Colorado has much higher need. And so if we just say that we're going with scenario 3 and we're going to send all the dollars to the Metro because that's where the people are, now we're creating significant disadvantage for the rest of the state where the needs may be higher. And so that's why I would be concerned if we go this path together, because now I would need to ensure as commissioner that I have a logical way to send funds down to ensure that people in both regions get the services that they need. And I don't think it's sound to simply send more dollars to the Metro because there's more people living there. All right, next slide. So is that great? Perfect. So we are at the place where we want to hear one another's why at this moment. I've shared my why as commissioner, and now we want to hear your why, and we want to ensure we also hear from the public. So thank you, Chairman Dorsheimer, and thank you, Yumiko.
Thank you very much for the clarity. It was very helpful. At this point, I would like to open it up. Do we have members with questions? Jamie, I see you've, please ask your question, Jamie.
Thank you. And again, thank you, Dr. Medlock, for these ongoing discussions. I feel like whenever we separate things, there's always the potential for one entity to get more than the other entity. And that's certainly, I think, some of the experience that we've had with the raise and other things that have happened within, you know, how funding is allocated. And I think that part of what's going to be probably primarily what's going to be the most successful out of any of these structures is the accountability and transparency for the BHAACs and working really hard to develop those accountability and transparency standards. But if we're trying to ensure that there's accountability and transparency to the entire state of Colorado, I guess I'm wondering, why do we need 2 BHAACs at all then? Why couldn't we just have an overall BHAAC and then utilize the regional committees to help influence those individual community nuances that we're really trying to do? That would be my first question. And then I'm going to throw in a second question just real quick. I know that's unfair, but and what methodology are we going to utilize based on whatever approach that we choose? How is the money going to be allocated?
Thank you, Director Ulrich. Other states have focused on having one entity as their intermediary to deliver services. In Colorado, we passed a law in House Bill 1278 that says we wanted a regional approach. And so I'm trying to get us as close as possible to the one BHAAC scenario while also following the law. And so that's how we got to a 2 BHAAC scenario. But you're absolutely correct that as we look nationally at how states have approached these issues, they try to have a single entity. And that process of having one BHAAC would be in conflict with the law that has been passed in Colorado to have a regional BHAAC approach. And so that would require statutory changes here in our state to allow that to happen. The second question I'm going to pass to our colleagues from Health Management Associates who are helping us with the deep dive on the financing of the BHAAC. So Angie, would you kindly either answer or delegate to someone to respond?
I am happy to respond, and then we'll certainly look to Roxanne to add additional detail. But one thing that I wanted to note kind of as the backdrop when we were looking at the analysis and when we were thinking about the approach to the BHAACs and just the fundamental paradigm shift, want folks to understand that the BHAACs are really responsible for assisting the people. And so in the backs of our mind, that was always first and foremost. So when you're thinking about the 2 BHAAC regions, think about it in terms of those 2 BHAACs are responsible for assuring that services are being provided and they are responsible for the individuals in those regions. So one thing to keep in mind is if I am in BHAAC 1, but I choose to go across the street to a provider who might be in BHAAC 2, I am able to do that. So I just wanted to highlight that BHAAC 1 then would still be responsible if I choose for whatever reason to go, down the block, down the road, across, county lines, because it's closer to my job. It's closer to where my family member is. It's where I just want to go because I trust that provider. That's something that sits behind all of this. So I know that there was some concern about that as we're thinking about the 2 BHAAC approach, but really we've designed this to kind of follow the people, and then the funding also then follows the people. So it's really kind of a shift where we're targeting our financing approach across those 2 BHAACs to be reflective of the individuals in those 2 regions. So I don't know if that is helpful, or Morgan or Roxanne, if you want to add additional detail at this point, but just wanted to highlight that that's kind of the bottom line approach that we were taking as we were, 1, thinking about the regions, and then 2, thinking about the financing and making sure that the financing then attaches to the people and is reflected then of the needs across those 2 regions, and really wanted to be able to balance that approach.
I think you said it well, unless there's something else we need to add, Dr. Medlock.
I agree. Thank you.
This is the list of the hands that I have up in this order that will take the next 3 questions. Seth, Raina, and then Tina. Seth, you're up next.
Yes. Hi, Dr. Medlock and council members. I actually appreciate the effort that was put in to like the 3 different scenarios of the different types of BHAACs, and based on the need of rural and frontier Colorado. Before I moved to Aurora to take, a job at a mental health center in Aurora in the metro center of Denver, I basically spent 2 years living back in Mesa County and trying to receive services there. And services there were like hard to find and subpar. So there's a huge need in at least Mesa County that I know of. And, I grew up in Mesa County, so I know that there's a huge need. And then I also understand that some of the facilities there might be kind of going through some shutdowns and reopenings at a later time. And so I just think that the resources need to be there. And I also think that as a peer specialist, there's a lack of like peer professionals in that area of the blue area than there is in the green area. But then part of me wants to understand is like, when I look at the map, part of me is like, kind of like, how does this cover, people that are Spanish speaking, refugee, LGBT youth, like I know that the Medicaid dollars say one thing about where the need is, but like if I look at like the makeup of the state, a lot of the minorities and different language speakers are in the Denver metro area. And then I would want to see an expansion of like services for ASL and for like access for people with disabilities. So I like, that's where I come from. And as a peer who tried to work in Mesa County, I wasn't able to get hired as in my profession as a peer. And so I had to move up here to take a job as a peer up here. And I've been working as a peer up here for like almost 6 years in first episode psychosis. And I know that there's like, I work for an Ascent team, and I know there's like 15 Ascent teams in Colorado because we've been expanding under the Office of Behavioral Health. And, we work with schizophrenic youth 15 to 29 at their first outset of psychosis. And so we've expanded like around Colorado as we grew. And I can kind of see the need in that population to like help them stay out of like hospitals and, having like emergency room costs be so much more expensive than putting peer services or more providers in the rural frontier areas. And so like I totally see the importance of the first scenario. I just have that question about like, does it also reach refugees? Does it reach, people who are Spanish speaking and other languages? Does it help people that are remote with ASL? And then also, does it help like immigrants who are coming in who might not be legal in the state, but are they able to get those services provided based on the scenario 1? That's just where I'm coming from.
Thank you very much, Seth. I just met with the county commissioners about this proposal, and one of the things that I highlighted is the structure of the BHAAC is like the scaffolding of a house. The pieces around what one experiences when they walk into that house are still the BHA's responsibility. So we still have the accountability of ensuring that our data strategy, our access to care strategy, our equity strategy ensures access irrespective of race, identity, language, ability, ethnicity, age. So we are still the entity that has to enforce that. I also clarified in the last meeting that this discussion should be tied to the rule rewrite process that I know many people in Colorado have been tuning into that each week, watching us change rules and standards of care across the continuum. That's where we're defining that the providers in these various regions, again, have to have a no reject policy, have to provide linguistically and culturally appropriate care, right? That's how those conversations now are connected to this conversation. So this is a conversation about, okay, how do we build the house? And then that conversation now determines now the experience, the type of paint we use, how do we ensure that there's access into the house, those types of things. That's how our rules and standards and quality of care framework now accommodate and complement this process of structure.
Thank you. Next up is Raina, then Tina.
Hello, everyone. This is Raina. I want to kind of build off what Seth talked about with the rural areas, rural and frontier areas. Concerns I have is that there's areas that have absolutely no services. And it's where, you know, with the funding streams, I worry about, I think of my own recovery and how I spent over 40 years trying to get help and I wasn't able to get that help because I didn't have a bunch of services that I needed available. Well, then those services did become available. And so I had more growth in the 2-year period than I did for all those 40 years. Well, then once we entered the second phase of the ACC, I saw a lot of those programs go away again. And I'm thinking I would have never recovered had I not had access to those different programs or interventions. And so it's where, when you're talking about the rural and frontier communities, it's like there's things that aren't offered to anyone. You know, there's just every rural and frontier community has different circumstances. Some are very wealthy and some are very poor, you know, and so some have more resources than other communities. But it's like, how are we going to build up? You know, I'm making an assumption here. If you live in the Denver area, I'm guessing that you can find somewhere in Denver to get whatever services you need. There's going to be some place that offers it for you that we don't have in the rural and frontier areas. So I just wonder how we can address that as far as funding. How, because we're like way behind the metro area in the rural and frontier areas where, you know, it may be a 3-hour drive to get to anything. And you may only have therapy available, but not these other programs that are critical to recovery. So how can we build those areas up?
Thank you for that question. And this is where all the moving pieces of the BHA have to be kind of brought together into one story. So about a month ago, we released something called the Community Assessment Toolkit, which was a place where we're helping local leaders inform us on what's missing at the local level. That is building into this larger process of how the BHA has to ensure that, again, there's actually doors to walk through at the local level. We're also ensuring that we're aligning with the federal mental health strategy for funding behavioral health. Things such as certified community behavioral health clinics is one example of that. And so we're trying to assess, does that fit in with our model here in Colorado so that we can take advantage of additional dollars from the federal government to put those dollars to work for people across our state. So all the pieces are working together. This again is just the foundation of the house. We've still got to think about the pieces that create that real home experience. And that's part of it, is having an actual door to go through, having a real person to talk to, and ensuring that we have quality, culturally responsive care across the state. So this doesn't immediately solve the issue of not having enough service types or providers. I do want to go for 1 second to scenario 3. In this scenario, if we can go to that, in this scenario, I think our problem gets even bigger, because now we have all the metro services in one BASO and the rest of the state to deal with in the other BASO. And so that's why I think this scenario in particular will bring risk, for the point that you made. And so although it's not ideal to split the metro, at least you have some resources to leverage for populations that are at highest risk, irrespective of which BASO they reside in. I hope that makes sense.
Thank you very much. Next up is Tina, then Robert, and then Tasha. Tina, we can't hear you.
When I put on my headset, there's an extra button to hit.
There you are. We can hear you. Welcome.
Okay, so I want to use a medical example to try and paint a picture here. In some of our rural and frontier communities, due to the distance that people are dealing with, many people have had family members or people that they know that have had appendicitis, right? It's kind of just a common occurrence, right? But it can also become really emergent very quickly, and it's very common that it can rupture. A child or an adult with a ruptured appendix, if that were to occur in Denver, there's many hospitals available, and it's a quick ambulance ride down to get service. But say that happened in West Cliff. That means that that child is going to have an airlift to a hospital. That means that the helicopter is going to have to come to them. They're then going to have to be airlifted, not to Canyon City, not to even Pueblo necessarily, because most of the time, to my understanding, their children's beds are full because there's so few there. They actually have to go to Colorado Springs or Pueblo or to Denver to be able to seek care. That means that those families are going to have to take immense time off of work to be able to travel, gain access to housing, and if they're lucky, be able to stay at maybe a Ronald McDonald house, take all that time off of work. It's multiple trips and tons of gas. And, you know, it's a wonderful thing that we have the ability to seek reimbursement for trips for medical appointments and those kinds of things through Medicaid, but there's a huge wait time for those things, and it's not an instant access. We have very few specialized services that are going to be available to families in some of these rural and frontier communities, which was also just stated. And due to that, being able to gain access to things like specialized services, like for eating disorders, there's huge travel, there's a lot of expenses, there's service gaps that then come into place. And granted, there's telehealth services that are a wonderful access point, but when you're looking at rural and frontier communities, there's poor phone service, there's lack of ability to have telehealth because we can't get good connection and internet speeds. The experience for that need for one-on-one service is immense. Having that one-on-one and person that you can speak with is really important. And being able to have access to that is huge. And sometimes what we are missing is the lack of ability to do that and the expense of being able to do that. So when we are are looking at being able to provide and have access to those services, these things cost a lot more and have huge gaps in availability for people in the frontier and rural communities, that if they are going to gain access to that, that means MedRide and all of these other services having to be accessed and costing Medicaid and Health Colorado more to be able to provide those services to members in these communities, to where we have a lot of access to public transportation and those kinds of things that are available in the Denver metro area that can cut the expense for members that have those things available there. I think that when we're looking at how to divide this, it's almost like we need to have 3 BHAACs and split the rural communities that are in this green on number 1 into 2, and have Denver Metro as 1 and divide it into thirds.
Thank you for sharing that recommendation. We can go back to scenario 1. Moderator, if we can go back to scenario 1 to appreciate the recommendation on the floor at this time. So I believe, just for the minutes, the recommendation is to consider a further split of the blue region. Is that correct? Into 2 regions. So that
I'm
there's
sorry.
a total of...
No, it was the, hold on. Let me flip through here. It was the one that took the Denver Metro and all of the green. So it was the defined Denver Metro. I think that's number 2. And then we had all of the green, and then be able to split all of that big green into 2 separate BHAACs, so that we could define the Denver Metro to be able to have their funding there, which is very specific to their area, and then be able to split the other areas, which have a lot more specific to tourism and very specific to the stresses of frontier community, rural communities, the stressors of not having access to public transportation and those kinds of needs, to be able to give a bolster to those things.
Thank you. That's noted.
Thank you very much, Tina. Next up is Robert, Tasha, and Raquel. Robert.
Hi. So I don't know if I have a question, more of like a concern or comment or just suggestion. So I definitely, scenario 1 is the one that is the most appealing to me. The only question I have and worry is working currently in the MSO system. I kind of understand like how it works and working with a few different MSOs. The thing that I get concerned about is and I know there's going to be bidding for it, but where the BHAAC offices will be. They'll more likely be in Denver, more likely be in the bigger cities. And then we just say we have a pandemic again, people are working from home. Zoom makes it really convenient to not have representation from the BHAACs in the smaller rural communities. So I think my biggest concern is as we move forward with this, and regardless of where we go, will there be BHAAC offices spread out through those areas? Will they just be a hub in Denver, and then their site checks once every 6 months? Because we know with weather, those site checks could get pressed out a little longer. We know with the convenience of Zoom, it's really easy to bow out when we have a lot of other things going on. So I think my biggest concern or just suggestion with all of this is it makes sense that the BHAAC headquarters would be in the bigger areas and that would be the hub. But how do we get representation? How do we get people that are going to be from the BHAACs in those communities to know those community needs, besides just talking to our leadership in those communities, but also really get a feel for what those communities go through, what their needs are. And sometimes, I'm just going to say this, being from a smaller community, sometimes we don't know what we need. Sometimes we need another eye to come in there. So I think my biggest suggestion and concern is whichever one we go with. Again, I'm voting 1 if we're voting on these 3. But if my biggest suggestion is that we have, mandated visits that make sense so that they could get a feel for the community, representation in those communities from the bossos in the form of an office, or I don't know how we would do that. I don't have a suggestion. I just know that is a need, because it's easy to see what we do in Springs, Denver, with our staff, with our workforce, and the things that we could do even in Pueblo and turn stuff around fast. How does that happen when we're in those smaller communities? We could know what the need is theoretically, but knowing what that need is when you see it firsthand, the way you do when you're in those communities and visiting those communities, I just think it's extremely important that if we're going to have the bossos located in the bigger areas, I would 100% love to see some offices sprinkled through some communities, or just some mandatory visits and some representation from those communities, maybe even hiring people to work in those communities with the bossos or contracting out. I don't know, but I just worry that we get lost in the shuffle, because sometimes we're the quietest and sometimes we're just on the fringe and we get forgot about. But so I just wanted to throw that out there.
Thank you for that. There should not be an assumption that a BASO office is going to be in Denver only. And so I do want to emphasize that, again, as part of the requirements that the BHA is enforcing. And, the only real context we have right now is how RAISE work. And I know that connection between RAISE and HICPUF is hard to understand, because HICPUF does not actually hold licenses for providers the way the BHA does. So the BHA is going to be much more closely connected to its BASO structure, because we're still the entity that has authority to license and designate across the state. So that's the key difference in how we should see ourselves, as setting up something truly unique, where the BHA still has significant authority because it's actually doing the licensing of all providers. And so to that end, as part of our requirements and what we expect of the BASO, is that it will be embedded in the local communities that it's serving. And that will be part of that negotiation process.
Thank you very much. Next up is Tasha.
Tasha's being sweet and letting me go first. Thanks, Tasha.
And Bob, sorry, this is Yumiko Raquel. Just 1 second. I want to make sure we also leave some time for public comment. So we'll try to squeeze in the last few BHAAC comments and questions here too.
I'll be quick as well. Go ahead, Raquel.
As somebody who takes care of I take care of two of those areas who are I'm on the divide, right? So if you're on a regional divide of those MSOs right now, it gets really difficult on what you can do. And what I heard you say, Angie, which was important to me, and I want to bring it back out. I heard you say that if I'm in El Paso County and Douglas County, because those are the two areas I take care of, on scenario 1, I'm going to be able to have equal services on both sides of that line. You were saying something about that being able to be, because sometimes we get to choose services like that when you live right on a divide, right? Like I can't always be forced. Sometimes there's not services on my side of the divide. So I need to go to the other side of the divide where there's services. And that's not just in my region, but I can tell that that's in other areas across Colorado. Is that what I heard you say, is that we'll be able to have equal services on both sides? And personally, I think what I like about scenario 1 is it seems to me that El Paso County won't be forgotten about. I've been taking care of that area for a very long time. And so it seems to me that it will be part in, and I also think that it's important that we aren't segregated so much regionally, where you city people over there and you regional people over there, because as somebody who actually comes from the city and moved to a rural area, I like the collaboration opportunities that Dr. Medlock talked about, and being exposed to new things that us on the region. I got sober in a very small community where I didn't have any idea that there were this many resources in the state of Colorado. I had to do this work to find out how much y'all even had in the city, and so the collaboration and actually having a city view of what the regions look like, I think it's a great idea. That we will have a little bit of region, our rural frontier. And I like to see that Denver is going to come in. I think it gives us an opportunity to not be so segregated. I think it's something that's going to end up not helping us, serving us as a community.
Yeah, Raquel, and I just want to highlight the point that you mentioned about being able to leverage across the geography where it makes sense and direct resources where they can, and have that economy of scale and that flexibility to really, look across the provider network and leverage all of that. So I just wanted to highlight that. But yeah, this is a different paradigm shift, because we heard not only from consumers of services about the challenge that creates when you're in one area, but the provider you want to see is in another, and you can't get to them because of this artificial divide. That same thing that we heard from individuals, seeking services and, receiving services, we heard that same issue from providers as well. Like, this is a challenge because people are coming to me, but they live in the wrong area. So we heard it, from both perspectives. So just wanted to highlight that as well. But
Thank you. Tasha, would your question be quick so we can move to a community question?
Yes, it's really quick. With these scenarios, even in living in these regions, like in El Paso County, I'm in El Paso County, there's not enough providers to even offer services to the people that are in the rural areas. And that is the biggest problem we're having. I live in Fountain, Colorado, and I can't even get the services that I need because there's not enough providers. That's the main key point that I have with all of these regions is there going to be enough providers to access the rural areas as well as the metro areas? Thank you.
Again,
Thank you, Tasha.
Sorry, thank you, Chairman Dorsheimer. There's so many moving pieces, and one other key piece we haven't mentioned yet today is that the BHA has a workforce strategy. And so the pieces that are moving, Tasha, are complex, but they're all part of this picture. And that's the other picture and piece we haven't yet talked about today, is that the community assessment toolkit, the workforce strategy, the rules and standards, all of those pieces go together and hand in hand to create this larger vision.
At this time, with the remaining time, I'd like to open it up to a Coloradan that has a question for today. Yumiko, I can't see those questions. If you can help me out, who?
Oh, yes. Sorry, Bob. We do have two hands up. I'm sorry, I don't know which one was first. We have Charles Davis and Megan Lovelace.
Charles, I have given you the ability to unmute.
Hi, thank you. Can you hear me okay?
Yes.
I apologize for my voice. I've got a little bit of a respiratory infection, so don't quite sound like myself. However, I will be quick. I want to thank the council for letting us drop in and hear about this. I think the thing that I have found over the years is that there are many what I call service deserts in Colorado. And so even though we've had statewide services, they haven't always been connected. And it seems like they've left it either up to the provider to get the word out across the state, or they've left it to the member or the patient to find it. And so I even ran across a situation where one community had started their own nonprofit to find residential services outside the state because they didn't know there were any in the state. And I think that's the kind of missing connectivity that the BHA would encourage them to figure that piece out, to make sure that the constituents know what's available. But secondly, I think the other piece was when I was able to dig into some data across the state, I was able to see it glaringly that a lot of areas weren't accessing residential services, one, either because they didn't have a residential in their area, or two, the people just didn't know what was available. So I would encourage to look at those two aspects. I think data is a very important tool for us as a system. And I haven't heard a lot about how the BHA will manage data and monitor data and utilize it to its full potential. Thank you.
Thank you for that comment. I think I gave folks a headache in the last meeting with our data analysis. And so admittedly, Mr. Davis, I did not bring that today, but we do have a chief data and analytics officer within the BHA, as well as a division of behavioral health analytics and epidemiology to ensure we have a statewide people-centered data strategy. I was told not to bring that to this particular meeting so that we could focus on people today. I see someone celebrating that I didn't bring those data points, but we are focused on a people-centered data strategy.
Thank you very much. We appreciate the people strategy today. And Charlie, we'll have another opportunity to do a deep dive into data, but we did feel it was necessary today to be people-centered. Miss Lovelace, if you could come off mute and ask your question, that would be fantastic.
Hi, thank you to this group and to the work you're doing for the state of Colorado. We're so excited to have a behavioral health administration working with and for us. I just wanted to point out in this scenario one, Lake is green and Eagle and Summit are blue. And what that means for a resident of Lake County who works and receives services mostly in Eagle and Summit County is that invisible divide will be there, both for the provider and for the person seeking services. So I just want to echo that. Yes, it's so important to have people on the ground in those communities informing the behavioral health administration real time to how these services are actually carried out, that this does work for both the service provider and the client at scale. So just a reminder, and I say that every single time. And then also, how does this work with folks with disabilities? How accessible are these services? We're still being told we should drive to Larimer County from Eagle County once a week to receive services. So while everyone on this call knows that's not a solution, sometimes the service provider doesn't have another thing to tell us. So as you're doing this, imagine you are a client seeking that service, or that you are the provider trying desperately to get that service to the client. Thank you for your time today.
Thank you to everyone. One of the rules that we have as BHAAC members is that we honor our time commitments that we have set. I do want to remind folks that there are going to be many opportunities to interface with the BHA, from providers to the recovery community to the prevention community. There's going to be information put out into the community where you can attend these seminars and town hall meetings and express your concerns and participate in the process. So most importantly, remember, we do have OwnPath that is being built out, which is a state resource where you can go look for providers. Understand that's still under construction and we're working with that, but please use it, provide feedback, get used to using it, which would be great. So at this point in time, I want to thank everyone for joining us today for this special session on hearing more about how we're going to change and improve behavioral health in Colorado. So we have a lot of tough questions, a lot of tough situations to face, and we can do this together. So let's remain open, let's remain honest, let's follow through with the transparency, hope, equity that the BHA stands for, and what Colorado asked for. So please show up, please participate, ask the tough questions so you can get the answers. And the more we participate, the better our behavioral health system is going to be. At this time, we can stop the recording and we are adjourned. Thank you, Colorado.